Blood transfusion in the UK is amongst the safest in the world, but nonetheless things can and do go wrong. And it's important that we're able to try and prevent any transfusion incidents and to be able to recognise them and deal with them if and when they do occur. So our learning objectives for today are to be able to describe the most common complications of transfusion, to use knowledge of transfusion risks in making decisions regarding transfusion therapy for our patients, and to be able to manage an acute transfusion reaction if and when it occurs, and to know when to seek advice and assistance. You're probably aware of SHOT, the Serious Hazards of Transfusion Reporting Scheme in the UK, where all hospitals report all transfusion incidents to them and they collate and present the data. Now, I'm sure probably most of the general public and probably a lot of healthcare professionals as well would say, if they were asked what's the most common risk associated with transfusion, that it would be infections such as HIV or hepatitis. But you can see on this pie chart they come under transfusion transmitted infections, shortened to TTI, and that's a tiny percentage of all the transfusion incidents that occur. And actually, far and away, the commonest transfusion incidents are those related to human error. And they're shown in all of the blue bits on the chart here, and mainly relate to incorrect blood component transfused and inappropriate and unnecessary transfusions. And we'll come back to discuss those in a moment or two. Now, transfusion is very safe. The risk of having a significant incident is very, very small. The SHOT data would suggest that a significant incident only occurs in 0.01% of all transfusions. But nonetheless, we can't be complacent, because every year in the UK there are a number of deaths associated with transfusion. And in the most recent SHOT report from 2010, there were 3 deaths which were thought to definitely be related to transfusion. And the causes are listed here. One was due to anaphylaxis, one due to transfusion-associated circulatory overload, shortened to TACO, and we'll speak a bit more detail about that later. One was a very rare event of hyperhemolysis in sickle cell disease. There were also 10 deaths which were thought to be associated with transfusion, with TACO being the most common cause in this list. Now, reassuringly, the SHOT data shows that over the years that they've been collecting data, the number of deaths attributed to transfusion has actually fallen, and you can see that in the line of this graph. The number of incidents reported has risen significantly over the years, but this isn't due to the fact that more incidents are occurring, it's just the fact that they're being recognised and reported. But despite this increase in reports, the number of deaths has fallen. And so that shows we are getting better at preventing serious problems and at recognising and dealing with them. So we're going to go on and discuss some of the transfusion incidents that can occur, including acute transfusion reactions, hemolytic transfusion reactions, pulmonary complications, infections, and a few others at the end. So first of all, acute transfusion reactions. So these are defined as reactions which occur within 24 hours of a transfusion, but many of them occur very acutely and can start within a few minutes of the transfusion starting. The signs and symptoms are listed here and are quite wide-ranging. The patient can become very acutely unwell very quickly, and obviously the most important thing to do if they get any symptoms is to stop the transfusion, check their observations, check the identity of the recipient with the details on the unit to make sure that the right unit of blood is going to the right patient. Call for medical help. Also call the laboratory, and I'll come back to why that's important later on, and investigate and manage the incident as appropriate. Now, there's a list of various possible causes of a transfusion reaction, and I'm going to go on and speak about each of these individually. So first of all, the mild reactions. There are 2 causes of this. The first could be a febrile non-hemolytic transfusion reaction. This is when the patient spikes a temperature, New guidelines actually suggest that a temperature rise of less than 2 degrees centigrade, but the patient's otherwise well with stable observations and the correct unit is being given to the correct patient. These incidents are much less common since we have introduced leukodepletion of all blood products in the UK in 1999. So it's not all that common that this arises these days, but if it does occur, it would usually settle with some paracetamol, and you can restart the infusion at a slower rate and just watch the patient closely. Mild allergic reactions can also occur, and the patient would generally have a fever, pruritus and urticaria, more commonly known as hives. This will usually respond to some Piriton, and again you're able to restart the transfusion and just observe the patient closely. Allergic transfusion reactions can become more severe, and as well as fever, itching, urticaria, patients can also develop bronchospasm, angioedema, which is swelling of the subcutaneous tissues and mucosa, including the tongue and throat, which can lead to blockage of the patient's airway and stridor. They can also get abdominal pain and drop their blood pressure. Management of this would include giving the patient Piriton, hydrocortisone, salbutamol nebulizers if they have bronchospasm, oxygen, and in severe cases they may also need some intramuscular adrenaline. The unit should be returned to the lab for analysis, and it's likely that the patient will require washed blood products in future, which can be supplied by SNBTS. An acute hemolytic transfusion reaction due to ABO incompatibility is hopefully something that none of us will ever see, but if it does occur, usually the signs and symptoms will come on very quickly, and again they're listed here so the patient can feel apprehensive, agitated. They can develop flushing, breathlessness, pain at venipuncture sites and in the chest, abdomen and flank. And in terms of signs, they can have a fever, drop their blood pressure, they can have oozing from wounds or venipuncture sites because they develop DIC, disseminated intravascular coagulation, and they can have hemoglobinuria. Obviously the most important thing is to stop the transfusion, check the ID details, and return the unit to the lab. There are some further blood tests that the lab would prompt you to do. And in terms of managing the patient, they should be given intravenous fluids to flush things through their system, aiming to maintain their urine output at more than 100 mL per hour. They may require furosemide to help with this, and in severe cases they may require dialysis. If they have bleeding as a result of DIC, they may actually require further blood components in the form of FFP and plasma. But obviously, as I've said, this is something that we hope we would never actually have to manage, and the main point regarding this complication is to prevent it. Now, this represents a form of a hemolytic transfusion reaction, an acute form, and hemolytic transfusion reactions lead to lysis of the red cells due to immunological incompatibility between the donor and the recipient. There is also a form of a delayed hemolytic transfusion reaction, and this is due to the presence of antibodies against other red cell antigens, which are only present in very low levels, which may have not been detected in the lab. But once the patient's been transfused, it leads to an increased levels of these antibodies and can lead to hemolysis, which usually occurs approximately a week after the transfusion. This tends to be less severe and the patient may not be all that symptomatic, but it is always worth warning the patient that if they do feel unwell, roughly a week after their transfusion, they should seek medical advice to have this checked out. Pulmonary complications of transfusion are being increasingly recognised and reported to SHOT. There are two main categories, TACO, which is transfusion-associated circulatory overload, or TRALI, and we'll come back to discuss both of those in a bit more detail in a moment. Patients will become acutely short of breath, and there are a number of investigations which can be performed to try and work out what's going on. So first of all, TACO. The definition of this condition is that the patient has any 4 of the following symptoms within 6 hours of a transfusion. So the symptoms include acute respiratory distress, tachycardia, increased blood pressure, acute or worsening pulmonary edema, and evidence of a positive fluid balance. As I've mentioned, this is increasingly being reported to SHOT, really due to increased recognition of this condition. But you can see from the graph that there is a significant associated major morbidity and mortality with this condition. Death shown in the purple parts of the chart and major morbidity in the yellow. There are fairly obvious risk factors for this condition: age of over 70, smaller patients, those with pre-existing heart failure or chronic renal impairment, and those with a low albumin level. Data from the SHOT reports reveal that it's not necessarily large transfusions that lead to this condition, and in the most recent report there were 18 cases of TACO in non-bleeding patients reported, and in 15 of these, patients had received 2 or less units of blood, and in 2 cases had not even received more than 1 unit of blood. As we mentioned, age is a significant risk factor for this condition, with over half of the patients who develop it being more than 70 years of age. This is just an example of one case which was reported to SHOT, just to give you a feel for this condition. So it was an 84-year-old male with congestive cardiac failure associated with ischemic heart disease. He was on regular furosemide and isosorbide mononitrate and enalapril, and he was admitted with melena. The hemoglobin on admission was 7.9 grams per decilitre, and as a result he was transfused 3 units of red cells, each being prescribed over 3 hours. However, because he was nil by mouth for an endoscopy, his oral diuretics were withheld and were not replaced with a parenteral diuretic. As a result, he developed pulmonary edema, was hypoxic, had to go on to CPAP and diuretics, but died as a result of this incident. So the most important thing with TACO, like many other things, is to try and prevent it. So when you're prescribing blood, make sure you take into account the patient's weight, fluid balance and comorbidities, and consider carefully what volume and rate of transfusion the patient is likely to be able to tolerate. If you have any concerns, consider giving them a smaller volume transfusion, giving it at a slower rate, and giving diuretic cover. And obviously monitor the patient carefully during their transfusion. Treatment, if they do develop TACO, is with diuretics and oxygen therapy. TRALI is a rare but serious condition which can be associated with transfusion. It stands for transfusion-associated acute lung injury, and the definition is acute dyspnea with hypoxia and bilateral pulmonary infiltrates during or within 6 hours of transfusion, which is not due to circulatory overload or another likely cause. It's thought to be an immune-mediated process, and there are thought to be 2 events which need to happen. The first is that the patient has pre-existing lung pathology, such as a chest infection, and a lot of neutrophils have already collected in the lungs. The patient is then transfused with a blood product which contains HLA or HNA, so that's human leukocyte antigen or human neutrophil antigen antibodies. So these antibodies attach to the neutrophils which have already accumulated in the lung. They activate the neutrophils, lead to release of cytokines, and lead to the condition. It's more common with FFP because the antibodies are found in the plasma component. And these antibodies are only really likely to be found in donations from people who have either had a transfusion in the past or who have been pregnant in the past. Now, obviously, in view of the concerns about new variant CJD, people who have been transfused since 1980 are no longer allowed to be blood donors, and so this has reduced the risk of TRALI as a result. We know that females who have had a pregnancy have a risk of developing these antibodies in 10 to 15% of cases, and as a result, recently the transfusion service has been trying to only issue FFP from male donors. If patients do develop this condition, treatment is supportive, and often patients have to be transferred to the intensive care unit and ventilated, and there is a significant mortality rate of around 6 to 9%. Now, this shows the incidence of TRALI over the past few years. Cases as a result of FFP are shown in the light blue bars, and due to platelets are in the purple bars. And as I've mentioned, FFP is now really used just from male donors, and this has significantly reduced the incidence relating to FFP. Unfortunately, platelets are not such a widely available resource, and it's not possible to restrict that to just male donors, and so we are still seeing cases related to platelet transfusions. It can sometimes be difficult to differentiate between TACO and TRALI. There are a number of factors that you can look at to try and tell one from the other, because management is very different. Patients with TRALI may have a temperature, but that would be very, very rare with TACO. The blood pressure would be normal or high with TACO, but normal or low with TRALI. The pulmonary artery pressure, if you're able to measure that, would be high with TACO, and the echocardiogram would be abnormal. As I mentioned, treatment is very different, because with TACO you would want to treat them with diuretics to get rid of some of the fluid, but diuretics in TRALI can actually make the patient worse. And vice versa, a fluid challenge will make patients with TACO worse, obviously, but can improve patients with TRALI. So moving on to transfusion-transmitted infections. As we've mentioned, viral infections are very, very rare, and I'll come back to that in a moment or two. Bacterial infections are really the thing that we worry about when we talk about transfusions-transmitted infections, and these are by far and away the biggest risk, and again we'll come back to that in a moment. There was a lot of concern a few years ago about new variant CJD, and thankfully we've not seen a huge number of cases, but again we'll discuss that in a minute. Parasitic infections are very rare, and obviously donors are screened, and if they have been to areas of the world where such infections are more common, they're not allowed to donate for a period of time. So as I've mentioned, bacterial contamination is the biggest concern. Patients can become very acutely unwell with fevers, rigors and hypotension. Management would be obviously stop the transfusion, inform the lab, and I'll come back to why that's important in a moment. Take cultures, give the patients IV fluids and broad-spectrum antibiotics. Now, this again is data from SHOT, which shows the number of incidents of bacterial infection due to transfusion over a year. The yellow bars represent platelets and the red ones red cells, and you can see that by far and away the commonest cause of bacterial infection is due to platelet transfusions. Now, the reason for this is that if any bacteria are acquired during the donation process, platelets are stored at room temperature, and this allows the organisms to multiply to levels where they can cause a significant infection in patients. There are a number of steps that are taken at the donation step to make sure that we minimise this risk. There have been new procedures for cleaning the donor's arms. The first few mils are discarded. But nonetheless, this remains an ongoing concern. So it's important when giving a platelet transfusion that you inspect the unit to make sure it's clear, it doesn't look as though it's infected. It's important when the patient's having a platelet transfusion that you observe them regularly. And if they do have a reaction, it's important that you inform the lab immediately. There are likely to be other blood components with SMBTS taken from the same donation, and these may go on to be issued to other patients who may suffer the same infection as your patient. So it's important that SMBTS are informed immediately so that any other components from the same donation can be taken out of the supply chain to avoid any risk to other patients. The risks of viral infections are stated here, and as you can see, the risks are very, very small. I guess the only one that still has a slightly higher risk is hepatitis B, and that's because the window period where the donor is infected but our laboratory tests are not yet able to pick it up is relatively long. So there are a few cases who can donate during this window period, but the risks are still very, very small. New variant CJD, there have been 166 cases of this in the UK to date, and 18 of those have donated. All recipients of donations from these people with variant CJD have been notified of their possible exposure, and there have been 4 cases of patients who have developed CJD which was thought to be related to a transfusion they'd received. The transfusion service have taken a number of steps to try and prevent transmission. All blood products are now leukodepleted. Plasma is imported for fractionated products such as intravenous immunoglobulin. Methylene blue treated FFP is used for people, it's actually now people who were born on or after the 1st of January 1996. And anyone who has had a transfusion since 1980 is no longer allowed to be a blood donor. It remains to be seen whether or not we introduced a screening test for donors in future. This has been talked about for a long time but hasn't been introduced to date. And there has also been a lot of work going on looking at filters to filter out the prions, but obviously we need to make sure we don't filter out other important components of the blood. And again, there's nothing which is ready to be introduced into clinical use at the moment. But thankfully the number of cases is very, very small, and hopefully this won't be an ongoing concern in future. So other complications, as we've already mentioned, human error is by far and away the biggest risk associated with transfusion. Incorrect blood components transfused can include wrong blood, and this often involves multiple errors. If an error is made at one step in the process, it's often not picked up. And so the final bedside check as nursing staff go to administer the blood is the most crucial point to make sure that you're giving the correct unit to the correct patient. We know that errors both in the laboratory and in the wards are more common out of hours, and so if at all possible we advise that only emergency transfusions are performed out of hours. Inappropriate and unnecessary transfusions I'll come back to in a moment. And the other group is failure to meet special transfusion requirements, in particular irradiated products. So inappropriate and unnecessary transfusions, this is being increasingly recognised by SHOT. And this is where the decision leading to the transfusion is flawed. And this may be that the wrong results have been looked at, transcription errors of results. It may be that the patient actually has a reversible cause of anemia, such as an iron deficiency, B12 folate deficiency, and they didn't really need to be transfused. Or it may be that the transfusion has been given at a dose or a rate which is inappropriate for the patient. It also includes events where transfusion has been delayed or not given at all when it should have been. So in the SHOT data, in the most recent report from 2010, there were 110 cases of inappropriate and unnecessary transfusions and 1 death resulting from this. 48 of the cases were thought to be due to people looking at the wrong blood results, and 52 were thought to be due to a lack of knowledge. So as we've already stressed when talking about TACO, it's important that you consider, is this the correct result for the patient, but also look at their fluid balance and what rate of transfusion they think they can tolerate. Iron overload, this is not a complication which is reported to SHOT, but worth just mentioning in the passing. We know that patients can develop iron overload after they've been transfused 25 units of packed red cells or more, assuming they've not got any bleeding. There are a number of iron chelators available. There is desferrioxamine, and there are new oral iron chelators. And iron chelation has been shown to be beneficial in children with thalassemia. It's often used in patients with good prognosis, long-term conditions such as myelodysplasia, but the evidence of this is not yet clear, and certainly the oral iron chelators are expensive. There are a number of metabolic complications associated with transfusion. These probably relate more to neonates and infants, or in adults if it's a major hemorrhage situation and they're receiving a lot of packed red cells. Hyperkalemia can occur because potassium is normally an intracellular electrolyte, but particularly if it's an older unit or if it's been irradiated, some of the potassium may have leaked out. Again, this would be more important really in neonates and infants. You can get a transient rise in glucose, but then the glucose level can fall as the insulin level will rise with the initial increased glucose level and takes a while to fall. Hypocalcemia can result because of the anticoagulant, the citrate that's in the blood components, which binds calcium and leads to low levels. And hypothermia can occur particularly in a massive hemorrhage situation if the blood is not put through a blood warmer. Obviously blood is stored at 4 degrees centigrade, so if it's not warmed first, it can lead to hypothermia. So just to finish off, just to give you a feel for the relative risks of the various complications that we've talked about, As we've mentioned, from a transfusion-transmitted infection point of view, viral infections, very, very low risk, but bacterial contamination is a significant risk and is something to think about if your patient becomes unwell. Immunological complications are rare, but again, we need to be aware of these and need to know how to deal with them should they arise. But as we've stressed, the biggest risk associated with transfusion is human error, so the wrong blood in tube or the wrong recipient, and these are things that we should be striving to prevent. So in summary, blood transfusion can never be totally without risk, so think carefully before proceeding to transfusion and be aware of the things that can occur and make sure you know how to deal with them should they arise.